Our case study today involves Reba C., a 45-year-old female who presented herself to the ER with complaints of fever, night sweats, fatigue, aching joints and muscles, chills, and chest pain. She did not go in under the assumption that she had the flu, but changed her mind when moderate chest pain increased to severe chest pain. She had a known history of drug abuse, including fentanyl and heroin. Her cardiac history stemmed from the drug abuse and resulted in degradation of heart valve functionality, necessitating a tricuspid valve replacement. The surgery was successful, and Reba was started on antibiotics, but did not finish the prescribed infusion as she left the hospital against medical advice when reported for using her IV for self-administration of illicit street drugs. Are there any guesses yet as to the cause? You can take a moment to pause if you would like, and then we can proceed. Reba C. had an EKG that showed dysrhythmias with widening PR intervals, a blood pressure of 86/62, pulse of 126, a temperature of 101.7, oxygen saturation of 92%, and weighed in at 114, though her previous weight upon discharge in her previous visit was 132. They performed labs that included blood cultures. Her CBC had a white blood count of 25,000 and a troponin of 9.41. There was an older injection site on the left forearm that appeared infected and expressed pus upon palpation that was then swabbed for culture. She was swabbed for MRSA and VRE according to hospital protocol for admission. A chest x-ray showed heart enlargement due to pericardial effusion. An endocardiogram was performed showing vegetation on Reba's replacement tricuspid valve. Blood cultures came back positive and were subsequently plated for culture. The wound culture and MRSA plate both showed positive growth, and per laboratory protocol, all plates were subjected to manual microscopy. The blood and wound cultures showed excessive growth of Staphylococcus lugdunensis and minimal Staphylococcus aureus. The MRSA test also showed positive, but minimal Staphylococcus aureus growth. The VRE test was negative. In this slide, we'll start in the 11 o'clock position and work clockwise to see blood culture bottles used for initial automated culturing and testing for blood samples, a blood auger plate with extensive Staphylococcus lugdunensis growth, a mannitol salt plate with minimal Staphylococcus aureus. These are most commonly used for MRSA, which is the methicillin-resistant Staphylococcus aureus organisms. The next slide is of MRSA, ending with a slide of a more densely populated Staphylococcus lugdunensis. Do we think we're almost there yet? You may pause again if you would like to take a guess, write it down, and resume. The irregular EKG, elevated troponin, soft blood pressures, and elevated pulse led providers to believe heart valve problems rather than blockage. The white blood count and elevated temperature was the indication for infection. All of this, with pericardial effusion and vegetation on the replaced tricuspid valve, led them to believe endocarditis. For the infection itself, MRSA was present, but a definitive excess of Staphylococcus lugdunensis. Endocarditis is inflammation of the endocardium. The base cause is an infection, though typically it requires that previous heart damage is present to allow invasion of the pathogen. If left untreated, acute endocarditis will kill you in less than 6 weeks. Staphylococcus lugdunensis is a gram-positive bacterium. It is normal flora on human skin, rarely infective. In fact, it wasn't even officially recognized until 1988, and only a handful of cases have been reported since then. However, of these recorded cases, with treatment, it still has a 38.8 mortality rate. As such, Reba C was scheduled for another valve replacement that was again successful. She was prescribed Vanco at 20 milligrams per kilogram per dose every 8 hours for 4 weeks. However, she eloped after 2 weeks of treatment. Blood cultures had been drawn shortly before she left. They tested positive, and further culture showed reduced but still present numbers. They attempted to follow up with the patient with no response. Reba C did return to the ER, but this time it was due to cardiac arrest from drug overdose, coupled with heart valve failure and sepsis. In summary, Reba C had a history of drug abuse, tricuspid valve replacement, and inconsistent, unfinished antibiotic treatment. Endocarditis is inflammation of the endocardium caused by an infection. Staphylococcus lugdunensis is normal flora, but was permitted access to an already compromised system. Reba C's history, plus the pathogen, plus poor treatment, caused her endocarditis and eventual death.